Excellent. Well, welcome to today's webinar. My name is Diamond Fernandez. I'm the founder and director of the HeartFit Clinic here, and we've been doing cardiac rehab and heart attack and stroke prevention for a long time. So this is kind of our expertise in what we do, and I'm going to share some important things that you should know about testing and treatment when it comes to cardiovascular disease. And so for those of you who don't know, like I said, my name is Diamond Fernandez. I think I'll try and get to the next slide here. So yeah, I've been doing this for a long time. I started my career with total cardiology. I was mentored by some really great cardiologists in Calgary here. And then I was there from 99 to 2005. And then 2005, I left them to, I got headhunted by a cardiologist in Montreal to start a clinic in Dubai, not my clinic, but theirs. And that's where I was exposed to some really great evidence-based treatments on exposing myself kind of on a alternative approach to treating cardiovascular disease. And that's where I learned in Dubai. Came back to Canada. 2006, I managed the cardiac rehab program in Kelowna. Still a great group. I'm in contact with them. And we're looking at wanting to open up a clinic in Kelowna. So it's been quite an experience there. And then I started the HeartFit Clinic in 2007. And of course, started it from, for those of you know, and have been with me for that long. I started with a small little room at the Trico Center. We moved from there. And now we're in our clinics here in Calgary. We moved our location here in 2016, I want to say, opened up in Edmonton 2018, 2020 in Vancouver. So I know there's some people from all parts there. So that's just quickly a little bit about myself. I don't want to spend too long on this talk. I want to leave it really open for some questions there, but I have a bunch of slides that I'm going to take you guys through to help you understand my journey and what happened on that side of things. So when it comes to heart disease, it's important to understand this part, is that there are three different pillars when it comes to cardiovascular disease. There's the electricity of the heart. So the electricity of the heart is, you hear about palpitations, and I'll get into that a little bit more. So there's the electricity of the heart. You can check that on your phone very quickly, or obviously feel palpitations. There's the structure of the heart. So when we talk about the structure of the heart, there's the chambers of the heart, there's the valves of the heart, and then there's the plumbing of the heart. And so the plumbing of the heart is what got me into this. And so I was so focused on making sure that the plumbing was okay. I forgot to look at some other things. And so anyways, the plumbing of the heart is very important, because most people think of that as hey, I got to watch out for clogged arteries. I got to make sure that my arteries are clean. And so that takes me in, of course, for those of you who've been around and knows me for a long time, I don't ever go through a talk by talking about this plumbing system. And so I just picked this from a website, and it talks, it's actually a plumbing company, I don't know, somewhere in the US or wherever it might be, but they're a plumbing company, and they're, they basically are talking about how the plumbing is like your cardiovascular system. So they're thinking of it back the other way. And so it was quite funny to see this. And so I always like to take it and talk about it from that end of it. And so, it's quite funny when I saw this website, I'm like, oh, I got to take a picture of this. This is crazy, because the plumbing talks about it like the cardiovascular system, people talk about it like the plumbing, and it's not that. So as you know, no talk of mine goes without saying that these arteries are muscles, not pipes. And if you don't believe me, you can feel them. You can feel them in the neck. You can feel them in different spots in the body where the blood comes close to the skin. And so where the artery comes close to the skin, you can feel it. So the pulse of the neck, the different areas where the pulses are. And these are not pipes. They have to deliver, these arteries have to deliver blood flow to wherever they need to go to, including the heart. And so a clogged artery is a lot different than a clogged heart. And then I'm going to talk a little bit about that. So these arteries are not a pipe, they're a muscle. And the details of these arteries are so interesting. And I've spent my whole career looking at this part of it. And I would say the last, I'd say 7-8 years maybe, is where maybe a little bit longer. I got exposed to this in 2009, 2008, 2009. And when you start looking, you find, right? And so I'm a big believer in that part of it. And so and it's true, you have a reticular activation of the RAS system you have in your body. And, it's like when you start looking at, I want to buy a red car, you see a red car everywhere. Same idea. I wanted to learn more about artery disease, and it presented myself. And I ended up finding some really great mentors helping me understand that these arteries are a muscle, they're not a pipe, and that we're getting it wrong. How my mentors earlier on treated cardiovascular disease, they talked about it, gosh, in 99 and 2005, it was all about a pipe. That's all it was. And I was even pushing stuff on that with my father. So for those of you who don't know, I got into this because my father had his first heart attack at 42. I'm 46, so I passed that age, but I ended up with something else, and I'll get into that in a moment. But we were so concerned about looking at these arteries like a muscle and not a pipe. And so that's the idea on that end of it, is that these arteries, if I attach all these arteries together, they would go around the world probably 2.5, 3 times. Like, that's how many arteries you have in your body. So they're very, very detailed, and I'll get into that in a little bit moment in today's talk. So when we go and talk about the electricity of the heart, when we talk about the electricity of the heart from that side of things, the electricity of the heart is very interesting, because all these things, when I talk about artery disease, they can all overlap with each other. You can have electricity problems because of a structure, or a structure because of electricity problem, or a plumbing because, so they all can overlap with each other. But the electricity of the heart, it comes from the autonomic nervous system. So it comes from the brain, and the brain tells your heart to beat. And when it's beating, so obviously the idea is when the heart's beating, you don't have to ask your heart to beat. It does it automatically. Now, if it's doing, obviously it's doing it automatically, or otherwise we wouldn't be here. We know that flatline is never a good thing. Always takes me back to that movie, Flatliners, I guess. I'm dating myself now. So that was probably in the 80s, I think it was. But anyway, the point is that, flatline is obviously not a good thing. So every time it comes off of electricity, it lets us know what's happening from that end of it. So anyway, that's the electricity of the heart. And when we talk about that electricity of the heart, it's completely different, but it can be related to the structure of the heart. Now, the structure of the heart, you have these atria, you have these ventricles. So here's the atria and here's the ventricles. And then you have these valves that open and close and let blood go through different spots in the body. So like I said, they can be individual problems on their own. So most of us are concerned from the plumbing side of things. But the electricity side of things, that can be a problem on its own, because there's an autonomic nervous system concern or whatever it is. And that's what we do in our clinic, is trying to find root causes as to why the electricity of the heart is concerned, or the plumbing of the heart is concerned, or whatever it might be from that situation. But we can actually see what's happening from the whole idea. We can get to see what's happening with the artery disease themselves. And so anyway, they all can interlock with each other. And that's really what I wanted to explain. And I can get into my personal story here right now. So I'm a pretty fit person. As you know, I'm a pretty active person. I can run up a mountain. I could run up a mountain. If you asked me in January, I could run up a mountain, no problem. But I ended up going to a hockey game, and I took a couple of my kids with me, and I couldn't even climb this flight of stairs. And I know heart disease, that's my gig. I know that really well. And so I managed to stay for the hockey game, and I couldn't even climb a flight of stairs, and I even couldn't climb the flight of stairs, even going to my seats. It was only a few stairs. And I remember telling my son, I go, look, if I have to go to the hospital, I'm not feeling too well. And he's like, what's going on? I go, I'm not too well, but if there's a problem, what you need to do, Diamond, is, or my boys, you need to go home with your uncle, and he'll take you home, and I'll make sure it gets arranged. But I told my son this, and so I ended up coming home, and so of course my kids end up telling my wife, and I was like, what do you mean you can't climb a flight of stairs? And she watches me climb a flight of stairs, and so I was huffing and puffing, and I was feeling this pain, and I'm like, gosh, this is just not right. And obviously I'm not 100%, and everyone knows their body best. Like, everybody is very intuitive with their body. they know when there's something wrong or there's something off. And I mean, I'm a pretty fit person, and I know when something's off when I can't even climb a flight of stairs. And so that was a problem. So obviously, being a guy, now I'm still a guy. So I get home and I couldn't climb the flight of stairs. So my wife says, I'm going to call the ambulance. And I'm like, no, don't be silly. I'm breathing here. I've got my pulse. I can check things. I'm good. I'm good. I'll get tested here this week. I got a lot of good connections in the city to be able to get things quickly. So I said, I need an echocardiogram. I just need to see what's going on, and I can look at that. And she's like, so she ends up in the background calling, we have a lot of doctor friends that are personal family friends of ours. And so they called it, my wife was calling them in the background, and next thing you know, an ambulance shows at my door. So yeah, I ended up, excuse me one second. So I got wheeled into emergency, and I'm with the emergency system, and they're all like hooking me up to the ECGs, and they're asking me, you feeling chest pain? I'm like, yeah, kind of, but it's not a heart attack. I know it's not a heart attack. Well, you don't know that. I go, I kind of do, but it's not a heart attack. And so I took the stethoscope of one of the paramedics and I listened into my heart, and I could hear something really off with it. And so I could hear one of the valves that were it was just a loud swishing noise. And so I told the paramedics, I go, it's not a heart attack. We don't need to worry about that. And they're like, it's protocol. And I go, fair enough. And so I get to the emergency department, and obviously I see the emergency doc, and he goes, well, good news, Diamond, it's not a heart attack. And I go, yeah, thank you very much. I know it's not. It's there's something going on with my valve. And he does a couple more tests to see what's going on, and talks to the doctor, and he goes, you know what, we can just send you home. You're not having a heart attack, so let's just get you going. It's about 11 o'clock at night now. And so cardiologist tells them, you know what, I'll see him in my clinic. I got some space here next week, and I'll fit him in, we can get through that. And so emergency doc comes back and tells me, relays a story. And I'm like, yeah, that won't work with me, nor will it work with my wife, because, she knows I know my stuff. And so if I'm here, let's just get an echocardiogram. And he goes, well, we normally don't do that. That's not something that we do. And I go, well, let's normally do it. So I told him who I was, and then there was that mutual respect. And, he says, let me call someone else. And he goes, well, Diamond, I can get you in his clinic a little bit sooner. It's the beginning of the week here. And so he goes, he probably fit you in at the end of the week or even into early next week. So that's really good. I got you that. And I'm like, that's still not good enough. And he goes, okay, well, let me call one more person. This is like 11:30 at night. So 11:30, 12, I don't know. It was later at night now. So obviously I had to do all this testing in the emergency. And so he called one more doc, and the doc said, yeah, I'll see him in the morning. I know who he is. And I won't say the cardiologist's name. So I know who he is. I'll see him first thing in the morning. So great. So I stayed overnight, and I slept in a chair like this. So it wasn't my usually comfortable bed. But I managed to get a few hours inside of this chair. It is a little benefit. This little footstool actually comes out and makes it recline, so it feels like a little bit of a recliner. But nevertheless, it was not a very comfortable sleep. And obviously, the nurses come in to bug me because I'm kind of emerged, but not. So it's about midnight. Go to bed. I'm supposed to have my echocardiogram, which is an ultrasound of the heart, in the morning. So I get that test in the morning, and of course, the tech knows me as well. I used to work with her at Total Cardiology when I was there. And she goes, yeah, Diamond, I know you, we used to go to the parties together. We had these Christmas parties all the time. Yeah, so I ended up knowing her. And I said to her, look, I really want to get this echo done because I feel that's what I need. And she goes, yeah, I heard you were trying to really push for this. And I go, well, I'm here. I may as well get it done, but I have to be in the clinic by noon. So I really want to get this done very quick and make sure I'm good. And anyway, the ultrasound basically looks at the chambers of the heart really well. So this is looking at the structure of the heart. So the structure of the heart is the atria, and the ventricles are right here. And what happened is they did the echocardiogram, and this is the mitral valve. So it's between the left atria and the left ventricle. And I had a flailed mitral valve, which I'm going to explain here in a little bit. So the blood flow, just to explain the blood flow of the heart. So the right side of the heart, to give you the education side of things now. So the right side of the heart carries deoxygenated blood. So it takes all the blood from the body that's got used, that doesn't have any oxygen, and it takes it into the right atrium. It pushes it into the left ventricle. And then once it goes into the left ventricle, sorry, my apologies. Once it goes, so right atrium goes into the right ventricle. Right ventricle goes out to the lungs to get fresh oxygenated blood. And then it comes back via the lungs into the left atrium. And once it comes back into the left atrium, the flow of blood is supposed to go down into the left ventricle, and then it goes out to the whole body. So this is what it looks like in the grand scheme of things. So you can see the deoxygenated blood comes from the circulation of the body. It then goes to the lungs to get fresh oxygenated blood, comes back by the lungs with fresh oxygenated blood. It comes into the left ventricle, and the left ventricle pushes it out to the whole body, and these arteries expand and contract to deliver blood to where it needs to go to. So what's happening is that my valve had severe mitral regurgitation. And what that means is that I'm having a backflow of blood going into my left atrium. So instead of flowing out through the atria, going out to the whole body, which it was still doing, but it was compromised in that a lot of the backflow was going back here to my atria. So what it was doing is it was enlarging my atria without even me knowing. And this has been happening for, gosh, I guess months before. But one of these cords, you can see these cords completely broke off. So think about like your Achilles tendon breaking off. That's what happened to my valve. My valve broke off and was just flailing in the wind. And so here's another picture of what you can see. So instead of the valves coming together, like this, that you can see, it's now not coming together. So it's opening. And one of these cords completely broke off. And so I have a valve that's completely leaking, and therefore it's pushing blood flow back into the atria. So it's going the wrong way. And it's kind of going into my pulmonary system, which is the reason why I couldn't even climb a flight of stairs at the hockey game. And so this is kind of what happened to me. And so obviously I was told at that point that I was going to have surgery, and that's I wasn't going back to the clinic. And so, yeah, I was told I was having surgery. So in order to have surgery, they had to look at the rest of my heart, right? Because, you have the electricity of the heart, which was compromised because I had a structural abnormality. Because of the backflow of blood, it was affecting my atria, therefore affecting the atrial signal, the electricity of the heart. So I was getting these palpitations. That's what I was feeling, the pain, and the backflow of blood was the shortness of breath that I was feeling. But there's one more thing that they needed to check, and that was to see how my artery health is. Now, this is my gig, and so I would have been really disappointed if I had artery disease as well. And so this is now looking at the plumbing of the heart. The arteries are not a pipe. We know that. They're a muscle. And so this is the picture of the angiogram, the CT angiogram that I went through. So this is virtual. So what happens is I go through this tunnel. I'm supposed to keep my hands above my head, and I'm supposed to hold my breath, putting me into this image. And it's a quick test. It's supposed to be like 10, 15 minutes. A lot of X-ray radiation. So it's not something I recommend for everybody, but I had to do it because I was going in for surgery. But it also lets us know the structure of the heart as well. And so when we look at the atria, the arteries of the heart, I had to see what's going on. So what happened with me is when I went in through this tunnel, right here, you can see, I don't know if you guys can see that screen here. I'm circling it with my mouse there. So what happened is that I could see my electrocardiogram on that screen. And I was going in and out of this tunnel, and I couldn't hold my breath and put my hands above my head. So I ended up going into a crazy rhythm. I don't want to say the rhythm. It's for those of you who don't know, it's atrial fibrillation, and SVT was happening there. And I could see it. And I know what I'm seeing, which even made it more dangerous. And so they couldn't do the test. Or I said, look, we got to stop the test. I don't want to do this. We're done. I don't want to do this. So they stopped the test. They pulled me out in the hallway, and I said, so the radiologist says, we really have to do this test. And I said, do we really need to do this test? Because obviously you could see what happened. And he goes, well, we'll do it a little bit quicker and I'll get the images really quickly, but we have to do this test. And I'm a team player. If we have to do it, I'll do it. So I went back in, got the images, and I found out that my arteries were clean. So at least I'm practicing when I'm preaching from that end of it. I take a bunch of supplements to make sure that my arteries are healthy, but we're wondering, okay, well, what happened here? And so I ended up staying, in the hospital, and this is a little bit emotional for me. So I was in the hospital and I had to do this surgery. And so this is a picture of my wife taking a picture of me before going into surgery, and just being a tough guy like I'm supposed to be. Anyway, thought I'd have challenges sharing the story. Yeah, I ended up having the surgery done, and gosh, I never thought I would ever go through this. And this is why adamant when it comes to looking at the arteries of the heart, whether you actually need to go through this. It's very important to be able to look at the needs of it. And so I took a selfie picture of myself afterwards, and gosh, I felt like I've been hit by a bus, and it was a real challenging thing. And so what they ended up doing with me, and I apologize to get technical with these pictures, you can just minimize it. So they ended up going on the side of my chest because I didn't have artery disease. What happened was they can do it minimally invasive. Now, it doesn't mean that it's not open heart. You can see it's open heart, but they call it minimally invasive because they don't have to crack my chest open, because they told me if we have to crack your chest open, you're going to have a tougher recovery. And gosh, I already had a tough recovery, so I couldn't imagine having to deal with that as well. So yeah, so anyway, I had the mitral valve. I had so many wires on my chest, and when I came out of ICU, it was touch and go with me for a little bit, but here I am. So yeah, I made myself back, and obviously the staff gave me a good welcome back here. Grew a little bit of a beard to show how long I was actually under the situation there. So yeah, I got some nice gifts from the staff here, and grew myself a beard. I'm a big Flames fan, as those you know, and of course this is where it all started. And now I'm the patient. I'm obviously got to exercise. I'm taking supplements to make sure I'm doing well. I've got medications that I have to take, and just to let you know, I plan on being on these medications for probably 3 to 6 months, and then I plan on getting off of them. Obviously, with consultations with a cardiologist, but it's a short-term thing, and I'll heal well from this afterwards. Obviously, stress is a big deal, so got to focus on that part of it. But I'm the patient now, and so I'm going through the experience of being on it from your end, and now I can talk to it from that end of it as well. So people always ask me about my progress through all this, and so if I talk about in February, I'd say yeah, I felt 100%. That was my level, and then I talk about February 19th is when I went into the hospital and wasn't quite myself, but I wouldn't say I was emergent. For sure, I would say I was not emergent. And so ended up obviously doing the surgery March 3rd, and I was going downhill in the hospital. I actually felt a little bit worse as I was coming to it, but surgery kicked my butt, kicked my ass, completely laid me flat on my back for a while. And it took me a while to come back. And I'd say, so March 31st, I got another echocardiogram, obviously on my doing, just to see where I'm at. And my heart functions are still a little bit compromised, but obviously I'm on the mend. And I'd say I'm probably about, 55, 60% of where I should be as what I consider 100%. So I'm not quite back to 100% for sure, but I'm definitely at a level where I can operate and do things. And every day is better. And if I really were to put it in this area right through here, I'd say it feels like a stock chart for me. So where it was up and down for sure, but you have good days and bad days and a lot of complications. I won't go through that part of it with you guys here, but anyway, that's kind of where I'm at today. Obviously, why I'm sharing this is more to share with you a little bit more of my experience. I think it's important to understand that part of it, but there should be a really, when it comes to surgery, and this is why I want to share this, because trust me, I was struggling with this for a long time. I'm the heart guy, and getting heart surgery, it's crazy. So there are benefits and there are risks when it comes to surgery, and the benefits have to outweigh the risks. And this is where I'm going to now talk about a lot more. I'm going to divert my attention from the structural, because I had a structural defect, and people are going to ask me, how did this happen? Like, you're super fit. Yes, but this is something that a mitral valve prolapse, and you can Google this, it can happen for many different reasons. And I had COVID back, a few months ago, and that could be something that exacerbated this situation. But I had an echocardiogram, so it's not something genetic. I was always thinking that I had to minimize my genetic risk of artery disease. And being 46 years old, my arteries are clean, but I have a structural abnormality, and which was then affecting the electricity. So understand that these all can interlink. And heart disease is more than just a clogged pipe. But now let's talk about the arteries as a muscle, not a pipe, because the surgery that I went through was minimally invasive. Gosh, I couldn't imagine if I had to do right through the sternum where they actually open up and do that. And they would have done that if I had artery disease, because then they would have done bypass surgery, which many of you are familiar with. So let's shift gears now and talk about the arteries, because most people, this is the preventable side of things. This is the preventable disease. Something that I went through, unfortunately, it's not, there's nothing I could have done. Absolutely not. Even if I found out about it a year ago, there's absolutely nothing I could do to stop the fact that I was going to end up having surgery at some point. It's just what it is. But with arteries, it's reversible, right? And this is where our passion comes into play to understand this. And when we navigate heart disease, and that gets into what I'm saying, I spent a little bit more time on talking about my experience. But when we talk about navigating heart disease, there's an emergency side of things, and then there's a non-emergent side of things, and that's super important to understand, because if it's an emergency, like I did, went into the hospital, they did an ECG. And when they do an ECG, you can see this segment right here. This is normal. This is abnormal. See how that segment got a little bit higher? That's what we call ST elevation. And that's what the paramedics and the doctors were looking at. And they're like, you know what, we're going to send you to the hospital and we're going to test your cardiac enzymes and troponins. And we're going to make sure that you're not having a heart attack or an artery disease attack. So a heart attack is, that side of things. So, or acute coronary syndrome, we might call it. So that is emergent. We got to do something quickly to fix this ST change that's happening, or that change that's acute. And so the blood work might show up. You can see it shows up a few hours later. That's why they kept me in the hospital. I think I went in the hospital at 7:30, and I was there till wee hours of the night to get this testing. And of course, I told you my story, how I slept overnight and slept in that garbage chair, and it was garbage, but I managed to get a couple hours of sleep, I think, but having to do the echo, hoping I would go home, and then realize, hey, we're not letting you home. This is really severe. We got to get you surgically implanted really quickly here. So, but that's the blood work, and it takes time for that to come up in place. So you can see the CK enzymes are a little bit quicker, troponins are just a little bit behind, but they elevate and then they subside over the next days as the heart is healing. And the heart tries and heals itself as well. So let's go through the treatment side of things when it comes to artery disease. And so if it's an emergency, they'll do the angiogram. Remember that tunnel that I went through? That's non-invasive. That's a non-invasive tunnel. There's a way of doing that where you go a little bit more invasive, where they go through a catheter. And the reason why they do that is so that they can stent it right away, stent the problem. And if it's not stentable, then they can do bypass surgery. And this is surgery where it's emergent. It's something that you have to do so that we can improve your health as quick as possible, right? That's where it's important. But on the non-emergent side, you have your family doctor that can check for cholesterol. They can, that's really check for blood pressure and diabetes. Those are important things to be able to look for. But they can do a stress test or a nuclear stress test. And what my concern is, and this is what I want to stop, is having to go from a nuclear stress test to doing an angiogram and making it an emergency. Now, there's a time and place, and I'll get into that in a little bit of a moment. But just getting to the artery anatomy, for those of you who haven't heard me speak about this, this anatomy of the artery is very complicated. I could spend another hour talking about this, but I promise I'll try and be quick. These arteries expand and contract. Inside the artery is all skin. It's called the endothelium. And you can see that right through here. So that's the endothelium. Now, as I zoom in on that, you can see that's the skin. That's the lining of skin. And that's the subendot. And you can see the colors are coded the same. it's a very complicated structure, and it's a barrier that allows different things to go in and out. If it's bad things like bad cholesterol, but not all cholesterol is bad. And for those of you know, I talk about it like a tennis net. That's why going to your family doctor and checking for cholesterol is kind of a waste of time, because the majority of heart attacks actually occur with people with normal cholesterol profiles. And so the artery is protected by a tennis net-like structure. Tennis balls don't go through, but golf balls do. And so these atherogenic or plaque-causing golf balls sliver into the artery and cause a plaque-building process to build up like a pimple on your face. And you can see that right through here. And I have good news is that I don't have artery disease. So I do all the testing. The funny part is I do all the testing here in the clinic. I've never once taken a stethoscope to my chest to see what was going on there. It just never occurred to me. I mean, I'm busy, maybe whatever, but I was always a guinea pig to get my arteries checked. I was a guinea pig to look at the function of the arteries. I was a guinea pig to get all the blood work to make sure I don't have a heart attack or stroke. And it never, like, I was always okay, but I was on top of it. I was on top of it with supplementation, with if you look at my supplement regimen, it's very detailed, because I'm looking at the deficiencies that I have. So at least I have something good to share, but the arteries were clean, and that prevented me from getting that full sternum opening that way on that end of it. But the arteries, you know, goes through this process to build up like a pimple would on your face. And if that pimple pops, that's a heart attack. And most people think of it like a plumbing problem. And this is the scary part. And this is about looking at the artery like a muscle, not a pipe. And most people look at it at the difference here. You can see that the vulnerable plaque, like I just showed you, it's just barely holding on by a thread, and it could rupture or pop inside the artery. That is a heart attack. If you have a stable artery, that's a good thing. Now the artery is stable. It's not going to plaque rupture. And when we talk about plaques, it's all about understanding the lipid-rich necrotic core. That sounds like a big word, but it's the inside lining. It's basically the consistency of that pimple, right? And so it can rupture, and it can rupture just a little bit. And if it ruptures a little bit, that's what we call a heart attack, but it's not maybe, it's called a non-ST elevation MI, so we may not see that on an ECG. Or if it's a full-on rupture, we're going to see that as an ST elevation MI, and that's a lot more severe, a lot more urgent to get to the cath lab to open that up as quick as possible. The cath lab is where we do the angiogram to go and look inside the arteries. So it's important to understand plaque stability, because most people would want to know, well, is my arteries clean or not? And that's where the HeartFit Clinic bridges that important gap to do testing that is non-invasive, no radiation, so that we can look at what's going on there, because you do not want to do these tests unless it's an emergency, right? And so here's another good picture to explain exactly that. So ischemia, discomfort, emergency versus a non-emergency. Here you can see this is non-emergent. That sounds funny. We got a plumbing problem here. This is the only portion of the artery that is open, but we have a supply-demand mismatch. So therefore, we might get what we call ischemia, which is a lack of blood flow. Now, at our clinic, we can improve that blood flow, we can grow new arteries, and we can do that without having to do a surgery. And surgery should be a last resort. And I'm going to explain the data there. This is acute. On this side is acute. You can see there's a thrombus there, which is not completely occluding the artery, but we have a plaque that's ruptured, but it's not fully occluding the artery wall. So that's what we call a non-ST elevation MI. It might be causing some limited flow, but it's not a STEMI, a fully occluded thrombus. So there are different types of arteries and how they present itself. And the most important thing is, well, Diamond, what can you do for us? And what we can do for you is strengthen the skin over that plaque so it doesn't rupture. That's the whole focus and what we're trying to do. But by understanding individually what your individual things are for the reasons as to going through that part of it. So how do we treat artery disease? And so optimal medical therapy is the way to treat it. But then I look at this and I say, you look at the number needed to treat on these medications, and it's not something I'd want to take long-term. Now, it varies for individual people, but optimal medical therapy is what we consider, okay, at least the gold standard to give to you if you're having what we call artery disease. If we find out you have artery disease. Now, if you have artery disease after finding out you've had a heart attack, now, of course, you have artery disease and you're going to be on this optimal medical therapy. And ideally, in the cardiology world, in the conventional world, you're on this for the rest of your life. Well, when you come to an integrative center like ours, we're trying to find out what the root cause is to why you ended up with that problem and try and get you off of medications as required. But there have been 15 years of trials showing that optimal medical therapy is just as good as going in and doing surgery. So this is what I want to share with you today. So here you can trial tested the PCI, which is doing a heart stent, versus the optimal medical therapy. They didn't find any difference. You can see the trial date. Here you go. It's 2007. We're 15 years away from this. We're still not practicing it 100%. There's the FAME trials that came up. There's the Orbita trial that showed a placebo effect of doing a stent. And then there's the ischemia trial, which came out, I think it was 2020 here. I want to say late 2019. But anyway, the point is that initial invasive conservative strategy for stable artery disease. What this trial showed, and this is probably one of the best trials to show this, is they basically showed, hey, if we go in and do a heart stent or bypass surgery, is that better than just giving the person cardiac rehab and medications alone? And I don't think they did too much cardiac rehab in looking at the study, but they were most concerned about giving optimal medical, and we didn't see any difference. Now, I changed my mind. Like this is like, hey, if I had a choice between doing a heart stent and invasive, remember, arteries are a muscle, not a pipe. If I had a choice of doing a heart stent or medical therapy, trust me, I would pick medical therapy all day long, even if it's short-term or whatever it is. But if I had a choice of doing surgery, where I'm almost like I was touch and go after surgery for me. I mean, my wife was at the hospital and she stayed there. I had to stay in CVICU for a couple of days just because I was so fit that I was stubborn and I wanted to rip out my cords and stuff. And so they had to put me back to bed, and it was a big deal. It was a big deal for me. So it was touch and go for me for definitely a couple of days, and obviously scared pardon my French, but scared the shit out of my whole family that way. But I think Jen tried and kept it to herself and told a few of our close friends, but it was touch and go for me for a few days. It took me 2 days to get out of ICU, which is normally, it should be only a few hours. And so if I had a choice between doing surgery and medical therapy, remember we're talking about the plumbing aspect of it, I would always pick medical therapy. Like it's leagues ahead, but there's more. I would take it even a step further and focus on further treatment that we do at the clinic here to make sure that what we can do. So what should we do to, when we shared when we should intervene is basically you got bypass surgery, which is taking an artery and bypassing it, physically bypassing, and they have to open up the chest to do that. And they harvest veins from the legs or the wrist to be able to do other bypasses that if needed on that end of it, or a stent. And those are the options that way. And my exception to the trial, and this is the only exception, is if you're having an acute heart attack. So if you're having an acute heart attack, you got to do a stent or bypass surgery, in my opinion. If you're having a proximal LAD or a left main disease and you're symptomatic with it, so those are the two suggestions. If you're symptomatic, meaning that you can't do what you want to do with your lifestyle, and it's it's proximal on the artery. So you have 3 arteries of your body. You have the right artery and the left that splits off into the circumflex and anterior descending. If it's proximal in that artery, I would suggest considering bypass or stent at that situation as well, depending. And that's situations we can talk individually in the clinic, but that's my exception to the rule. Anything else, if you had a blockage, down here, I'd be like, let's try a non-invasive way. And if we need to go there, we can always do that. Right. So that's my exceptions. And then my next book is called Death of the Stress Test, because the stress test is looking at it from this side of things. I'm going to bring all this out. The stress test, why I think a stress test is actually a really good test, because it lets us know if you're ischemic or not, meaning lack of blood flow or not. But we already know then, okay, we got to go into treatment side of things. I hate the fact that some people have to go do more radiation, which is a thallium scan or a MIBI scan. Majority of times, we already know the area and location of the artery disease from the treadmill test. And more importantly, treating the patient symptomatically. If they're going through that and they're asymptomatic, give them medical therapy. So there's ways, because you don't always need to know the anatomy. Like I got to know my anatomy, and trust me, I would never have done that test unless I really, really had to. but I had to do that test because I was going through that surgery to replace the structural issue. And so the angiogram is what has to stop. And that's why the death of the stress test is not, hey, let's just stop doing stress testing. I don't like the outcomes of the stress test. And so the outcomes of the stress test are two things. It's just two things. Either, hey, you know, you got a Diamond, you got a clean bill of health, and I can pass the stress test with flying colors, no problems. And I rightfully should, but either I have a clean bill of health, which I could still be on the path of a heart attack or stroke. Why is that? Because the artery has to be, think of it like a plumbing problem. I had a slide, and I think I forgot to put it in there, but think of it like a plumbing problem. If the artery, you remember, inside the artery is all skin. So if you think about it like a plumbing problem and think of it like a highway system, 4 out of the 5 lanes have to be closed on that highway system for it to show up on a stress test, right? 4 out of those 5 lanes have to be closed on for it to show up on a stress test. And that would warrant doing an angiogram. And I don't always think that's the case because we already know the area that is occluded and we can see what's happening. So that's why I don't think further testing should happen maybe 1 out of 10 times, not 10 out of 10. And 10 out of 10 times, doctors send you to a thallium or do an angiogram, and that's unnecessary. That's not choosing wisely. That's not, that's being, oh, I just want to know the anatomy at the expense of now, you know, 800 chest x-rays here, probably 800 chest x-rays here. It's a lot of radiation. I don't ever suggest going through that. And this is invasive. Inside the artery is all skin, right? And if you go poking around in that, that's not going to be good either. And so what should you do? Obviously, ECP therapy should be a treatment option that you could do to grow new arteries and improve that heart function. And emergency is an emergency. If it's an emergency, like I had a structural emergency, that's a structural concern. Emergency is emergency. Hey, you got to deal with that. Like that's where cardiologists excel. That's where they're really good at what they do. That's why I had a fantastic stay right through the hospital the whole way through. I won't say too much about the emergency department, could use some work, but anyway, that's another story. But the emergency, it's emergency, right? You got to deal with that. But if it's non-emergent, stable artery disease, this is a way to go about doing it. Stable artery disease is symptom management, medications, and understanding your risk and why you ended up with that. And so stable artery disease is treating with external counterpulsation, exercise and nutrition, and even some supplements from that end of it to find out where your deficiencies are. So that ends my talk for today. And I'll welcome any questions that anyone might have. I see some thank you for the comments there. I appreciate that. Sorry to get a little bit emotional, but I didn't think I would, but you know, it's a life-altering event that you end up going through, so.
Yeah, can I talk?
Yeah, absolutely. If you want to unmute yourself, you can unmute yourself and we can ask the question that way, or you can use the chat, whatever you prefer.
Yeah, I had a thallium test a month ago, and I was told that there is a blockage in the left side artery down somewhere, and the ischemic activity probably started at 9.1 met. So my ejection factor is 35%. And do you think I can come to you and you can assess my position and guide me what to do next?
Absolutely. I think that warrants an individualized consultation where you can meet our medical director. She's our nurse practitioner here, and you can have that conversation where she can go through your situation a little bit more. Obviously, we want to make sure it's safe and effective to do what we recommend. And I think, yeah, you'd be a great candidate to be able to do that. I definitely would like to know, you know, next steps. Do you need to do an angiogram or anything like that? Those are all things that, you know, we can explore in that consultation. But if you have artery disease, I think it's important that we go about now reversing or treating it from that end of it. So I think that's super important. So hopefully that answered your questions. Yes, we can help you. And that's part of what, so I have, I'm super passionate about this. I got passionate because of my father. You know, he had heart disease when he was 38, I think it was, and 42, he had bypass surgery. And my uncle, he passed away at 42 from this. So I was like, so gung-ho about, hey, I want to know everything I can so I don't end up with that situation. And so, and I have not ended up with that situation. I ended up with a completely different situation with a structural abnormality that I could not do anything about. So it's, the irony behind that's a little bit funny, but you know, from the family side of it. But what fuels my passion is the success that we've had with our patients over the years, and that's super important to help people reverse that disease process to help out with that side of things. So that's stuff that we can definitely help out with on that end of it, and go through that. And everyone's individual. Everyone has their own story to see what's going on. And anyway, hopefully that answered your question there.
Right.
Simon, I have a question.
Thank you.
Can you hear me?
I can hear you. Thank you. Yeah.
So you having had this event now, I've never heard of this anyway. How would you recognize it? Would you have recognized it in someone else if they came to you with the symptoms?
The irony of it is yes, because when you come see our nurses, they do a head to toe examination. I just never have done that. And so any one of our nurses, if they put their stethoscope to my chest at any points, I just never did that. I just never had I was always doing the testing and they were testing me, but they're like, oh, we'll skip the head to toe assessment because you're okay. But they never, really, the irony behind it is really crazy. All that had to be done is just, if I was really a patient going through our process, yes, we would have caught it.
And how common is this?
You know, I don't know how common it is. There are a lot of valve abnormalities that can happen. Remember, I'm going to take us back to the slides where I think I should bring us back to this slides here. Hold on one second, sorry, because I'm going to talk a lot to this today. But I'll take us back to this slide. You know, structural abnormalities can happen. You know, you can have a birth defect. That's a structural abnormality, or a valve concern like I had, or an enlarged chamber like an atria or a ventricle. That's structural issue. But that structural issue could be on its own, or it could be a result of a plumbing problem, right? Or it could be a result of an electrical problem. So I see I'll get to that question with the AFib there in a moment, but you know, if you have atrial fibrillation, yeah, what's it doing to affect the structure of the heart? Or is there a reason why? Because of the arteries. And so I'd want to get to the root as to what's going on. And so to answer your question, Evangeline, it's a little bit, yes, to answer your question, yes, we would have caught it if it were any other patient coming through our clinic.
So what were your symptoms other than that day at the hockey game? Did you have symptoms previous to that?
You know, looking back on it, I can pick and choose some things. Like I have an exercise routine I do in the morning that involves 80 push-ups. And I was wondering why I was never getting any better than that. And so there's little things I'm like, oh, okay, maybe that. And I had COVID. And so, you know, I couldn't run up a hill as well as I could have. And so I attribute it to COVID. I just got to get my fitness back. So, you know, hindsight's 2020, but I don't think I would have changed anything. Like there's no way. It was very fluky how this happened to me. And most people, like I told my wife not to call emergency, but I knew that there was a problem. So I was due to get an echocardiogram probably that week anyway. So I would have gotten one. I would have known what to do already, like, because I already heard the problem. Well, I would have heard the problem is really what I'm trying to say.
Well, I'm glad you're okay.
Thank you. There was a story here. Oh, thank you for the amazing story. You also suffer from permanent atrial fibrillation, but no one's recommended for surgery. You have mitral valve prolapse as well. I would recommend that you have your echocardiogram. You can have a consultation with our staff, and they can talk about that more specifically, because I would want to see the echocardiogram, and I would want to get into the root as to why you have atrial fibrillation, because you're just taking probably a blood thinner to make sure you don't clot and send a risk of stroke. And then I get into CHAD score, and I can do really a whole talk on that part of it. But the, obviously, no one's recommending for surgeries, because probably you don't have severe mitral regurgitation, which is the backflow of blood hitting the atria. But I would need to look at your echocardiogram a little bit more closely to give you that answer there. So sorry to not give you a complete answer, but just call our clinic. We can go through a consultation and we can do that for you there. So thanks so much. Yeah, so thank you very much for those comments. I appreciate that. Someone had a stent installed in November, suffered a mild stroke that caused hemianopia of both eyes, lower quadrants. Stents are not a cure, and they can occlude. And so this is why medical therapy is showing just as good as a treatment option as doing a heart stent, and so, or even bypass surgery. So there are risks to doing any surgery, but anyway, I want to know a little bit more about why you ended up with that stent, and you can, for you having sent that message, I'd like to learn a little bit more about that situation. You can contact, all of you can contact our clinic, and you can book that consultation and get that questions answered that you have that specifically to you, so we can customize it from that end of it. Can improving artery health help reduce symptoms of atrial fibrillation, if that's the reason why you have atrial fibrillation? Atrial fibrillation can also come from the autonomic nervous system. So there's reasons as to why you have that. I'd want to look at all of that. So it's a little bit of a puzzle for us to kind of get through. So if that's the reason, if that's the underlying cause, yes, but I think it can be more than that as well. It's to look at the autonomic nervous system, which most physicians don't do. So are you able to share the New England Journal reference, either typed here or email post? Sure, I can just write it to everybody. It's called the ischemia trial. So I'll just put it in here. You can just Google that. Google is good enough for that. So just look at that part of it. Thank you. Yeah. I think I'm missing some. I'm gonna pick some of these here. So I'm just trying to read all these comments. I think, it's always important to keep testing, keep understanding where you're good for. There's a time and place for going, use us. Like, trust me, this is all I do is heart disease. And this is all our clinic focuses on is heart disease. And so we're really good at that part of it. So use us to understand when you can use the healthcare system to when you can use us and when you should be doing these tests important that way. So would you prefer see a stress test before coming to your office? No, I don't think that's necessary. It doesn't tell me anything unless you've already gone for it. So it's not going to change anything. My book, Death of the Stress Test, is because it's designed to look for ischemia. It's designed to look for a supply-demand mismatch. So I don't think you need a stress test before coming to my office or even seeing a cardiologist, because the testing that and that's not to say that we wouldn't recommend you seeing it. It's all about everyone's individual. Everyone's an individual person. And so that's where I like to come from this angle, is to say, look, let's just start off with that conversation. Let's see what's going on with you. And sometimes, our nurse practitioner or our medical director will ask you to do a test before coming to see us, but just everyone's different. Everyone's different as to what's going on and what's happening on that. How do you measure success, and have you compiled results? I have so much results. I haven't put it into, and it's funny because our CACPR, which is our organization that I'm actually incoming president, are asking me for that literature. I've got so much data inside of this clinic. It's crazy. I just need a student to come in, just put it all together to compile all the literature. But yes, we've had a lot of success, and how we measure it is by seeing changes in what we do. So yeah, thank you for posting that article there.
Diamond?
Yeah.
I just wanted to speak specifically. I'm so glad to see you. Thank you for sharing this deep, deep story. When Glenn and I have come to you and we've had all our tests done and we have 9% and 6% chance of heart attack. And how long does that was my question of where do we go from here? Because my MD wanted me to have a thallium test and they had me running on the treadmill for up to level 11. Because it wasn't bothering me at all. And I was so sick afterwards. It was so painful. And I had interstitial tearing in my arm from the needle. And I mean, it was just awful. I should have probably just demanded that I came to see you, but I thought we'd kind of already deemed everything. My doctor was trying to get a baseline because I had to get a new MD. Yeah. So how often should we come to you once we've had testing done and sort of been given the bill of health?
Yeah, to me, arteries can take 6 months to a year to change to the good or bad. So I think it's important to look at it, and it's case by case basis. I'd say anywhere from, 6 months is a little bit too quick. So sometimes depending on the situation, right? But I'd say as early as 6 months for someone who's high risk to maybe even 2.5 years out. Like everyone's individual on that side of things. So I'd say, looking at it every couple of years is important, and not doing everything. You don't need to do everything. We can just handpick some of the tests that you can do again and again on that end of it. So
I think we missed that. I think we thought, but of course the body's ever changing, but you kind of think, okay, we're really healthy, we're really good, but with a family history, as I've just learned now, right, with you and your dad, that was our big draw too, because we'd had parents with heart disease. So,
of course, yeah. Thank you very much. I appreciate your comments too. So
thank you.
So can you expand on supplements to assist in reversing calcium score? I think that's, again, an individual thing. If you have a calcium score that's anything like, if you have a calcium score that's elevated, let's say 50 plus, I'm going to say. So if it's 50 or more, you got calcification of the artery. What a calcium score doesn't tell me is the non-calcified lesions. And so it's important to understand why and what's going on. And every body is different to how we go about reversing that side of things. Now, I can guess and going through that part of it, but that's an individual consult that we can go through to decide what supplements that you can get from our clinic to help you with that part of it. So large atria. So yeah, I think there's some extra comments here. I think, I might be looking at some cardiac rehab following up in your office, and that's important. Like, thank you, Marty, for posting that comment. I think there's lots of things going on with you that I would love to see in the clinic as a consult and decide whether, what we can do for cardiac rehab to help out with that side of things there. So, but yeah, there's lots of different things that we can do. And coming back to this avenue of it, and I can't stress this enough, if you have an electricity problem, I want to find out why. Is it the autonomic nervous system? Is there a structural abnormality, or is there a plumbing concern? If you have a plumbing concern, you have a plumbing concern. It can then affect the electricity of the heart, or it can then also affect the structure of the heart, right? If it goes too long. And then the structure of the heart, is it because, so they all can link with each other. And that's why I wanted to end with this slide, is because it's important to understand the different things that are happening from different things. And so if you've done that, if we've looked at the autonomic nervous system, if you've looked at the plumbing, if we've looked at the structure of the heart, then it's about just, doing the best we can to replace or fix the deficiencies that we see and help you get heart health. And that's individualized from that end of it for sure. So I know there was a comment here that a stent was installed after the angiogram, 80% and 50% blockage. I don't think that's always a need to do an angiogram, and that's where the ischemia trial shows that. And it's been going on for decades, a decade plus now. So on that part of it. So there's a good question here. Exercise, nutrition, supplements, which one yields the best for improving heart fitness, and how would you prioritize these? I think they're all important. Exercise, these arteries are muscles, not pipes. And so it's important to improve the elasticity and improve the function of these arteries. Nutrition, what you eat and put in your mouth, is very important to what is healing. And supplements are super important. If you're taking medications, you're going to have there's toxicity that happens inside your body, just what happens. And so it's important to replace deficiencies as a result of being on those medications, or finding out why you're deficient, what your deficiencies are, and replenishing those deficiencies as to what's going on as well. So yeah, they're all just as important. I think what you put in your mouth is super important. So nutrition, supplements, exercise, all that's super important. Have I seen more problems caused by COVID and caused by the vaccine? Yes, there's good data coming out with that part of it. So the answer is yes. What about a blood pressure record? I think that was asking. Yeah, it's important to keep a blood pressure record, but I want to find out why you have high blood pressure. And that's another thing from that end of it. And if someone posted, if they have high triglycerides, should I keep testing it? Yes, because we want to reverse it if you're doing something to reverse it. And so, but triglycerides, so to end on that, triglycerides or there are different buckets that we look at when it comes to cholesterol. And there's the good, the bad, and the ugly. And I've talked about this, but when you go to your doctor's office, they're just looking at a bucket of triglycerides and saying it's high or low. I'd want to know what the consistency of that bucket is. Is it larger or smaller? And accordingly, then we go about treating that side of things on that end of it. So I think I went through all the questions there. If I'm missing anything, please, I probably missed it because I'm at the end of the chat. But if you can kindly put that there. If there's any more comments, I'll stay for another minute there. And then, or you can unmute yourself and talk through that there. So, but I'll just give it another minute there.
Oh, Diamond, what do we call in and book for a follow-up? Or
you can just ask for a follow-up consultation from your
with you?
With me or even Tanya, either one. Okay. So here in Calgary. So yeah.
Okay, thank you.
No problem. So angiogram is clear, and cardiologist mentioned autonomic system. So I'll be interested in consult, objective heart health. Many thanks. Anyway, thank you very much for the comments, and thank you very much for all your support there. And yeah, I didn't expect it to be so challenging to share my story, but it's still raw, I guess. So if there's no more comments or any questions, thank you very much for taking the time out of your busy days to listen about how to navigate heart disease, and kind of went off topic a few times, but hopefully not too much. But I wanted to keep this inside an hour, but there's always—
Hello.
Yes.
Hello.
Yes.
Hello.
Yes.
Are you hearing me?
I can hear you. Yes.
Okay. I'm Robert. I'm actually a patient of yours. Well, I'm with I live in Burnaby, and I'm curious about a lot of things. You're mentioning that arteries are a muscle instead of a pipe. Have you convinced the rest of the medical profession of that? And the second thing is that I went for the assessment. I didn't get everything done. I got most of it except for the blood work, but they put me in the exercise bike because I'm visually impaired, and they thought it might be easier. And I was able to do quite a little bit on the exercise bike, and yet they're telling me, little things like, they check, arteries and whatnot, not everything, but there are some deficiencies. But what I'm curious about is, if fit people have heart disease, how can they manage to continue doing what they do without any problem? So to me, it's questionable, because if you're fit and you can, say, run a marathon, and you have heart disease and you're not bothered by it, then what is there to do?
I think you've taken a first step, and thank you very much for that. But to answer your first question, convincing cardiologists that these arteries are a pipe, not a muscle, they know that. They should be aware of that. I just don't like the analogy that they use. It's just that they have a certain amount of things that's in their toolbox, so they arrange it to being that way, and it's just legacy in how they talk about it. I mean, I learned that when I started my career, and we were in a tight office. We were like 1,000 square feet, and I was right next door to the cardiology group when we're doing stress tests, and I got mentored. I got, in my opinion, I'm very grateful for that. I got mentored by some of the best cardiologists in the city, and they would bring me in the room and teach me, because I was very I was coachable. I wanted to learn. I wanted to learn everything that, and they were teaching me a lot of what's going on, but they taught me that the arteries are a pipe, not a muscle. And, you know, it's a plumbing problem. It's always a plumbing problem, but that's in 99, 2000. And it's the literature started to come out to show that a little bit differently. And it's not a clogged pipe analogy. And that's not how the problem happens that way. So anyway, that's kind of to answer that question. So I think the literature, it takes a while to catch up on that side of things. It's not about convincing. I think most cardiologists are smart and they know that there's I don't think they go into the detail of the anatomy of the artery like we do, because, you know, all they give you to treat artery diseases, all they have in their toolbox is a statin. And I think that there's a lot more that we can do than just a statin. And so, and to answer your question, I think to understand your deficiencies, to keep, if you're living with heart disease and what we can do to help you out with that part, I think it's just important to make sure that you eat well, supplement well, and be able to help out from that end of it. So that's a little bit more individualized, and I'd love to have another conversation with you offline about that part of it. Thank you for the question there. I think in the interest of time, again, anybody who wants to come in for a consultation can come and do that. That's not a problem. And anyways, I want to thank you for listening in and taking the time out of your busy day to be here. And obviously, we're here to help you live happier, healthier, and longer. So have a wonderful night. And there'll be a recording of this as well for those of you who missed it.